everybody, and welcome to Parkinson Place. I'm Alex Redmond, and thank you for joining us for Power Hour. Today's topic is how and when to think about neuromodulation as a proven therapy option for Parkinson's disease. We are joined by Chad Davey. Now, Chad is a representative. Some of you guys might be familiar with him if you've attended our seminar. He's a representative with Abbott's Deep Brain Stimulation Division, and he supports Southwest Florida in and around Sarasota, Tampa, Fort Myers, and Port Charlotte. Chad works closely with neurosurgeons and movement disorders neurologists in his region, and he frequently participates in supporting patient education programs. Chad is a Sarasota resident, for those of you that live on the Sun Coast, and he loves taking his boat out into the beautiful waters right here in Sarasota with his family. Let's welcome Chad. He has a couple of words to say.
Awesome.
Hi,
Thank
Chad.
you so much. Good morning, everybody. Thank you so much for having me today. I actually go back 5 generations in Florida, 4 right here in the Sun Coast. So I love this area to death. I am, as Alex said, your local Abbott representative. So my email is on the screen right there. I'll also have my phone number available for you through Alec and supporting cast over there at Parkinson Place. If anything ever comes up or questions that you have about DBS or physicians in the area or anything around Parkinson's, please give me a call. And again, Alex and Parkinson's Place, thank you so much for putting this on today.
Absolutely, absolutely. And also now we are being joined by Sri Palavaram. Dr. Palavaram received his PhD from Vanderbilt University, following which he worked on research and development for several aspects of deep brain stimulation, DBS therapy, and technology. At Abbott, Sri has served in medical affairs, and in his current role, he oversees education initiatives related to DBS therapy for the Southeast United States. Sri is heavily invested in the clinical deployment of Abbott's recently FDA approved technology for remote programming in DBS. At the end of this lecture, we'll send out a couple of links, one of which was an article in the Augusta Chronicle with this new technology, and the other is for a cooking event with Dr. Fiona Gupta from last month's webinar. So welcome, Sri, and here you go. You can say a couple of words.
Thank you, Alex. Thank you, Alex. Yeah, we're very excited to partner with Parkinson Place. This is our second lecture in a 4-part series. We have an amazing speaker today for all of you. I've had the pleasure of working with Dr. Falconer for at least a couple of years on education initiatives. He's one of the best presenters for patient education events and an extraordinary clinician as well, and an early adopter of the remote programming platform. So I'm very much excited and looking forward to his talk today and questions through this event.
All right, perfect. And also, we are joined by our wonderful speaker today. We have Dr. Falconer. Dr. Falconer is, his first name is Dr. Drew Falconer. He's a board certified neurologist and he's a fellowship trained movement disorder specialist. He is the director of the Inova Parkinson's and Movement Disorder Center in Virginia, and he's associate professor of neurology at the Virginia Commonwealth University School of Medicine, Inova campus. Dr. Falconer attended medical school at Tulane University, and he did his medical internship from the Louisiana State University and his neurology residency and movement disorders fellowship from Georgetown University. He specializes in advanced care of patients with Parkinson's disease, essential tremor, dystonia, Huntington's disease, tic disorders, and other movement disorders. Dr. Falconer speaks nationally on various topics in movement disorders, and he's a respected national educator in Parkinson's disease and deep brain stimulation, otherwise known as DBS. He's a native of New Orleans, and Dr. Falconer currently resides in McLean, Virginia, which happens to be where Larry Hofheimer is from. He is the founder of Parkinson Place. He lives there with his wife and his 2 children, and in his spare time, he enjoys cooking and spending times outdoors and LSU football. So welcome, Dr. Falconer. Take it away. We're so excited to have you here.
Thank you. It's a pleasure. I think the host has blocked my video capability. So if you guys could oh, there we go. Now the button has appeared and now I appear. Thank you, Alex. I appreciate it. Thank you to Abbott for bringing us together today. I'm looking forward to this time together, and I'm hoping that we can get from this a deeper understanding about neuromodulation on down. But in reality, let me give you a little more background of myself. So my name is Drew Falconer. I am a Parkinson's and movement disorder specialist, as Alex said, here in Northern Virginia. And I have the privilege of directing a pretty sizable Parkinson's center. We have 4 specialists that all we do 5 days a week is try to deliver an elevated level of care. And I think we take care of about 3,500 Parkinson's patients overall. Now that has allowed me, through my position, to really spend the last 5 or 6 years of my life seeing the difference that modern therapies can give to patients on their journey with this thing called Parkinson's. And so I want to come to you today, not only as a specialist who does this every day, but as a partner in this for you, because I want you to come away from this talk being armed with the tools you need to have a good conversation with your doc about the path forward. Because it is no secret that we treat Parkinson's differently today than we did even 10 years ago. And that difference comes from having better tools to treat this. I mean, remember, folks, we have 23 medicines as of today that go towards treating the root cause of Parkinson's, where 15 years ago, we only had like 3. We have 5 wonderful pieces of technology that are life-changing to Parkinson's disease, where even 6 years ago, we really only had 1. That explosion of advancement, of development, of tools simply gives us an armamentarium that we can go to every day to try to find a better path forward for you. But it takes having the courage to talk about it, and it takes having the knowledge to have a good informed conversation with your doctor when things aren't working. Because this is what I want you to get from today. And we'll, of course, go into Parkinson's. We'll go into DBS. We'll go into where these tools are placed. And then we'll have a nice Q&A at the end where we'll talk about it. But what I really want you to get from today is a big old ounce of hope. And this is hope that comes from the fact that no matter where you are on your journey with Parkinson's, no matter where you are on that road, no matter what symptoms you have or what's holding you back, because of the tools we have options that we can use to try to make it better. So you will never be at a point of being out of options. You will never be at the end of the alley, end of the cul-de-sac where there's no way out. There is always something we can do or deploy to try to help. And that in and of itself is a message of hope. So on that topic, let's start our conversation today. Our conversation on Parkinson's, on advancing therapies, on how we treat this in 2021. Let's start by actually hearing from somebody who has Parkinson's disease. This gentleman's name is Olson, and he is sharing his story with us to kind of set up as we go through this, where we are and what we need to do. And I think this will resonate with a lot of folks on this webinar in terms of his experience.
And I've had Parkinson's about 10 years. The main symptom that really grabbed my attention was when my hand started shaking, and it was violent. I generated a spreadsheet of 43 different symptoms that I had. Like, I lost my sense of smell. Of course, my balance was terrible. I was unable to sleep at night. Most of the times I'd sleep 2 hours, that'd be it. And so then I went back to doctors time and time again, and it took them 3 years to fully diagnose me. They said, you have Parkinson's and your whole life's gonna change. Really a hard thing to swallow was that, hey, I'm not going back to work anytime soon, maybe never, because I was a full-time engineer, plus I ran a company. I used to work 12 to 14-hour days, 6 days a week. I was not able to sculpt any longer. And so that was a real tough thing for me, because I'd been sculpting for 15 years to get to that point. Like, wow, I really got it. And then it's gone.
So that's Olson. And his story, I hope, resonates with some folks on this call. Just that journey towards an answer, that presentation of symptoms that were changing things, And the medical community around us may be missing the ball in taking time before you reach that point of saying, this is Parkinson's disease. Now, while that is, I'm gonna skip, there we go. While that is a commonality for a lot of folks I see, I do find it to be almost cathartic once you do label this as Parkinson's, once you say, this is what you got, and then follow it with the truth that is, you're gonna be okay. Your life expectancy with Parkinson's today is the exact same as the life expectancy without Parkinson's. So the road's gonna be the same length. We just have to be a good partner together to make sure that your journey along that road is the best we can make it at every point. But before we get into how we do that, it always bears taking a moment to just set the stage for what this Parkinson's thing is. And what I mean by this is the thing that I say about 10 times a day, if not more. And that is that I want you to remember something. Remember, Parkinson's disease as a condition is not a structural problem in the brain. We're not dealing with a tumor. We're not dealing with a mass. We're not dealing with a stroke. We're not dealing with permanence of injury. Because if you have a stroke, it is what it is. The damage is done. We have to work around it, right? Well, Parkinson's disease is not a structural problem. It's a chemical one. Your brain, by having Parkinson's, is not producing the neurotransmitter dopamine, the hormone dopamine that you need. It's not making enough. Your car that's driving around with an empty tank of gas, and it's our job to fill that tank in as smooth, predictable, and consistent way as we can to get you better. Now, that deficiency of dopamine actually builds up over time. So by the time you come to see a doctor and the doctor says, I think this is Parkinson's disease, by the time your diagnosis occurs, usually that deficiency is already at a 60 or 80% deficit. So you're the car again, where if the tank goes to E, the light comes on, and that's when you're usually diagnosed. And the symptoms of Parkinson's are varied. As you heard Olson say, he made a spreadsheet of 40 some odd symptoms. But what I'll tell you is this, is that by the time you're diagnosed with Parkinson's, remember that deficiency, the tank is empty by about 80%. Well, something is happening for 5, 10, 15 years beforehand when the tank is slowly coming down. And usually what happens is that as that tank is coming down, patients get symptoms such as a loss or an absence or a reduced sense of smell, constipation, sleep fragmentation, talking or acting out your dreams. Usually that triad of sense of smell change, GI that transit change, and sleep changes, that usually predates diagnosis by 5, 10, or 15 years. Just this idea that as the tank is coming down, these little symptoms are popping up. But it takes that deficiency being very profound before the big symptoms like slowness of movement, difficulty with dexterity, and tremor starts to come out. But here's the thing, and I want you to do this every time that Parkinson's disease seems nebulous, seems complex, or seems incredibly onerous in what's going on. And this is what I do every day in clinic, I promise. If you have a long list of symptoms, if it seems like everything in the medicine side and symptoms is way too complex, what I want you to do is take a step back, take a deep breath, realize you're going to be okay, and think about this as the chemical deficiency that it is, because it's just a chemical problem. And so all of this laundry list of symptoms that go into Parkinson's boil down to a failure point that is just your tank being low. What that means is, if we don't get lost in the trees, if we just take a step back and view this as a chemical problem, then fixing the chemical problem should bring those laundry list of symptoms in line. And if this is a chemical problem, then throughout the day and night, because you have Parkinson's 24 hours a day, throughout the day and night, at any point, your tank of dopamine is either full and good and your symptoms are controlled, it's underdosed and your symptoms are come out, or it's overdosed and we get side effects. And if we really view your day as a chemical problem that we need to fix in as smooth and consistent a way as we can, then the potholes or the changes during the day start to make sense. And then we have options in terms of therapies we can deploy to try to fix it. Now, we classically diagnose Parkinson's disease, and most people still do, based on your story. So we get your history, it fits with the symptoms we expect, the general slow progression we find. Then classically, we give you dopamine back. So it's called a dopamine challenge, where we will start a medicine for Parkinson's. If Parkinson's is due to the deficiency, we give you the chemical back. You should do better. And it's that response to medication that classically helps us seal the deal for, yeah, this does look like Parkinson's. Now, for the past 11 years, though, we have had a wonderful piece of technology called a Dat Scan, and that's what you're seeing on your screen right now. Now, Dat Scan is a type of nuclear medicine scan that actually takes a picture of the dopamine system of the brain. It's this idea that in the brain, and you'll see it on the far left here, that in a normal brain, the brain is filled with its normal level of dopamine. It has the transporters for dopamine humming along at a full capacity. And so we tend to get this bright comma shape in an area of the brain that dopamine runs through. Well, if you have Parkinson's, your body is not making as much dopamine, and thus it's not making as many transporters. And so with Parkinson's in a DAT scan, those commas tend to go away. So this is a good reminder to folks out there that we do have a brain scan we can use that will tell us in color if this is Parkinson's disease. It's a great tool that we deploy often in patients who are kind of in the gray area where the symptoms and medicine response aren't exactly a slam dunk. It's always good to have objective data too. But remember, folks, with Parkinson's disease, we are dealing with a chemical problem. I'll say it 1,000 times. In fact, I want to put it on a t-shirt and just wear it around so people will know this is a chemical problem. It's not a structural one. And with that, we have a whole host of medications that we can deploy to help. And so what I want to spend a minute doing is going through the main 4 categories of medicines that we have that treat Parkinson's disease. Because at the end of the day, if you as a Parkinson's patient, if your loved one who has Parkinson's, if you find that your day fluctuates, if you find that there are periods where you feel better, periods where you feel worse, periods where you may get side effects of medicine, such as a little over-energizing, dyskinesia, a little bit of sweating, a little bit of just feeling agitated. If you're fluctuating during the day, remember, those fluctuations are not truly your Parkinson's. The fluctuations are the medication. All your body is telling us when you're fluctuating during the day is that your deficiency is really reliant on us giving that chemical back. You are a type 1 diabetic who needs insulin to function, except in this case, it's dopamine, not insulin. And so if you're fluctuating during the day, that's your body just saying, I'm living and dying by the pharmacokinetics of the drugs you're taking. And so that tells us that we just need to do it better. And to find that path for better, to feel confident to tell your doc, I'm fluctuating, we need to try better, it always bears taking a minute to go through the categories of medicine so you'll know what you're taking and the limitations and benefits of what you got, right? If you're using tools, it's good to know how they work. So let me get my little annotate tool. There it is. We'll do blue today because that's a happy, fun color. So the 4 main categories of medicine we have are all intended to give the brain dopamine back, right? We'll start here at the bottom with the main one that most people are on, which is Levodopa. If I ask for a raise of hands for folks who are on this video, if we had cameras on, it would probably be the vast majority of folks are on or have been on Levodopa for Parkinson's. It's the thing that the majority of patients are treated with out in the community and specialty centers, and for good reason. When Levodopa goes to the brain, your brain takes off the Levo group, here I'm going to put a line through it, and look what's left, Dopa. So Levodopa is the most direct way for your brain to get dopamine back. It is the precursor to make dopamine. It's like putting fuel directly in the tank. It's like giving insulin to a type 1 diabetic. So when you take Levodopa, we get more dopamine, the little green dots, in the cleft. Now, Levodopa dates back to 1968. We knew in the 50s that this medicine was a life changer for Parkinson's, only because it was the first way that we could actually give the brain back the thing it needed. Now, what we discovered very quickly is that if you give people Levodopa by itself, most people would all of a sudden become profusely lightheaded, dizzy, pass out, and a lot of people would start vomiting. Never a fun thing. So in the 1960s, we realized that we had to add Carbodopa to Levodopa. And if you all see today the medicines you're taking, be it an old Sinemet or newer Rytari, it's all Carbodopa and Levodopa. The reason why is because Carbodopa keeps the body from activating dopamine outside of the brain. It keeps you from having the side effects of Levodopa by itself. And so that's why the old trade name was Sinemet, which was supposed to be cute. It was supposed to be Latin for sin emesis, or don't vomit. Because when you add Carbodopa to Levodopa, your risk of vomiting essentially goes away. Now, this is important because in our Carbodopa-Levodopa medicines, the second number, the Levodopa, is the active ingredient. So if you're taking a 25 100 milligram tablet, we talk about that in terms of 100 milligrams of Levodopa because that's the active drug. The Carbodopa isn't. And so it's important when we communicate about these drugs, be it old Sinemet or even newer Rytari, that when you communicate, you do it using the second number because that's the active drug and that's the one we're concerned about. Now, Levodopa is a life-changing medicine. It works, especially early in Parkinson's. But the thing to remember about original Carbodopa-Levodopa is that that drug dates back to 1968. That drug has been around a long time. And because of that, in the 60s, we were good at making drugs. We weren't very good at making delivery systems. And the limitations of original Carbodopa-Levodopa are things that people tend to feel. And that limitation is that when a person takes Carbodopa-Levodopa, it hits its peak after about an hour and then drops precipitously like a stone at hour 3 to 4. So most people on classic Sinemet get about 3 to 4 hours of benefit. And it's not a very smooth benefit because usually people can feel themselves climbing the roller coaster, then they can feel it crashing, needing their next dose. This is important because if 80% of patients out there, according to Michael J. Fox Foundation, are only treated with original Carbodopa-Levodopa, and the majority of patients are fluctuating during the day, then a big part of why that is because of our reliance only on Carbodopa-Levodopa from the 60s. And so what I want you to do is not go to your doc and say, oh, I heard this guy talk and he said the Carbodopa-Levodopa is junk and you're a terrible doc, blah, blah, blah. No, I want you to realize that we have known that the ups and downs of old Sinemet have been a problem since the 70s. And that all of the drugs that we've come up with since then, all the therapies, including DBS, have all been created to try to fix the ups and downs of old Carbodopa-Levodopa. And so that's an important thing to take with you, because if you're fluctuating, of course, that is the foundation of your therapy. It's the center point of your conversation with your doc. Now, how do we make that better? How do we extend the Carbodopa-Levodopa? Well, in the late 1990s, or early 1990s, sorry, we came up with the COMT inhibitors. The old one was entacapone, which you have to take with every dose of Carbodopa-Levodopa. And the newer one is a medicine called Ongentys, that's once a day. Now, COMT inhibitors are great drugs if used properly. They work by blocking the breakdown of Levodopa. So when you take Carbodopa-Levodopa, be it in Sinemet or Rytari, that medicine has to go into your mouth, has to go into your stomach, has to be absorbed through the small intestines, and then travel through the bloodstream to get to your brain. Well, in all of our bodies, there's this system called the COMT system that is slowly eating up the Levodopa as it's trying to get to its target. So you have to think about it sort of like the COMT system is Pac-Man, and it's eating up the little Levodopa beads as they're trying to get up to the brain. Well, if we block the COMT system with entacapone or the newer one Ongentys, it gives our Levodopa, the foundational therapy, a big boost. Now, the challenge with entacapone, which is taken with every dose of Carbodopa-Levodopa, is that it doesn't last very long. The half-life of old entacapone is about an hour to 2. And we've really come to understand that by adding entacapone, the old Comtan, it just makes the roller coaster bigger. And so if you are on Carbodopa-Levodopa and entacapone, and your urine is bright orange, you're having some issues with diarrhea, which both are very common with that medicine, and you're still fluctuating, that's a good reason to talk to your doc about adjusting to newer, smoother agents to try to help. Now, the newer medicine is called Ongentys, which is once a day. That doesn't affect your stomach, doesn't give you orange urine, and it tends to really boost things in a smoother way. Now, outside of the COMT inhibitor, in the early 2000s, we came up with these medicines called dopamine agonists. So there are three of them. The first is an older medicine called ropinirole or Requip, and then there are two newer ones. One is called pramipexole or Mirapex, and the newest is actually a patch called Nupro or rotigotine. Now, the dopamine agonists work not by giving you dopamine back, not by giving your brain the precursor to make it. They work by simply mimicking what dopamine is supposed to do. So dopamine agonists go into the brain and just stimulate the receptors and essentially pretend to be dopamine. They tend to work very well, and they tend to work better in younger patients or people earlier in Parkinson's. And they're nice because all three versions have a once daily form. And so if we have that problem of Parkinson's all the time, then the best way to fix it is in the longest, smoothest agents we can. And dopamine agonists fall into that category as an agent we can add to Carbodopa, Levodopa, or even use on their own. And to me, they have the benefit of being 24-hour drugs. Now, the final category is way over here to the right. They're called Mao B inhibitors. Now, Mao B inhibitors have been around for a while. There's a number of them. The one we tend to use the most is a medicine called rasagiline or Azilect. Mao B inhibitors don't actually add dopamine to the system. What they do is they block the breakdown of dopamine. So think about the brain as a bathtub, and that the Mao B inhibitors are clogging up the drain to keep the dopamine, the water, around longer. And Mao B inhibitors are great because they're once a day, and they boost not only the medicines we're giving you because they block the breakdown, but they also boost your natural dopamine. So they're a great medicine to add on to things because they can really boost things and stabilize things for a longer period of time. So those are our four different categories of medicines, and should segue naturally into this timeline. Here's what I want you to notice. 1910, we first synthesized dopamine, figured out it was part of the equation. It was 1960s that we came out with Levodopa. That was the first time we could give the brain back what it needs. Released Carbodopa, Levodopa, Cinemet CR, a regular Cinemet in 1968, 1972. True, the chalky little tablet, the same one you're taking today, came out. And then in the 90s, we had the COMT inhibitors. We had Cinemet CR, the older extended release, which is a really challenging, crummy drug during the day. And then in the 2000s, we had this explosion of advancement with Stalevo, Apokyn, Nupro on down. And then in the 2010s and up to date now, we have seen more therapies come out, even non-dopaminergic ways to approach Parkinson's, that we have, I'm telling you guys, we have so many options in terms of the therapies we can use, that just saying there's not a next option is absolutely inexcusable these days. But here's the deal. All of those therapies, the vast majority, require the GI tract. And they require you to remember to take pills. They require those pills to go through the stomach, where they can get delayed by food, by a fatty meal, or by delayed gastric emptying. And then they have to transit through the GI tract to work. And if you're constipated, which in the world of Parkinson's, the data says 85% of folks are constipated, but I always joke the other 15% are just shy about it. And they don't mention it because it makes them shy, but everybody's constipated. If you're constipated, that means your gut isn't working the way it should. And so these pills can get stuck. And if they get stuck, they don't work as well. And that results in more motor fluctuations and problems with the medicine working. And so that's the challenge, is that we have these tools that are wonderful, but they have to make it from the pill shelf to your brain to truly work. And so the problem is we are really dealing with folks fluctuating between three different states. Those three states, like I mentioned earlier, are all due to this chemical deficiency. And so they are a state of either being off when the medicine is not working well, the medicine is letting you down, your symptoms are coming out. There's on, which is when the medicines are working, you feel better. And then there's symptoms of too much, which is like dyskinesia or excessive movement. So we have a patient here on the screen who's going to show us these 3 different states for this person. But just remember that everybody's different. Everybody experiences on time where they're good, off time where they need help, and symptoms of too much. Everybody experiences it differently. And remember, folks, most people don't have dyskinesia these days. So we've gotten pretty good at getting away with the symptoms of too much. But let's see what this gentleman has. So when he's on here on the left, you can see he has maybe a little bit of tremor coming out on the left. I would still adjust his medicines to make that better. He can walk fine. He's running down the hallways, grinning ear to ear. But when he's off, when his medicines are letting him down, and that's important because when you are having symptoms during the day, that's not truly your Parkinson's affecting you. It is, I get it. But think about it not in that way. Think about it that it's when your medicines are not holding you. You're a diabetic, and that's the moment where your sugar's 1,000. We got to do better with the insulin to make sure you're better, right? Same with this. If you're having off periods, that's a period during the day when the medicine is letting you down, which gives us a whole host of options to medicate and treat the sucker better. So for this gentleman, when he's off, you can see he has a really pronounced right-sided tremor. His steps are a lot shorter. He can't move as easily, more stooped. He has worse expression in his face. And the dexterity, I'm sure, is much, much worse. And then for this gentleman, when he takes his medicine, he also has symptoms of too much. Dyskinesia, this hyperkinetic, excessive movement that we all worry about, that we think about with Michael J. Fox, for instance, that's not a symptom of Parkinson's. Remember that. If you have a patient with Parkinson's who's not treated, who's on no medicine, they will never be dyskinetic. Dyskinesia is a symptom of too much. It's a sensitivity to the medicine, or it's a time during the day when we're overshooting it, and that's the result. And so for this gentleman, you can see it's very stereotypic. It's a hyperkinetic, big movement that he can't control, almost the opposite of Parkinson's, right? Parkinson's is a very constrained, tight, slow, mild tremor, but not big movement kind of disorder. Dyskinesia is when we've ramped it up too much, and now we have excessive, uncontrollable movement. Let me skip through. There we go. And so that's what we're fighting. That's the bear in the room. We're fighting the fluctuations of the day. And early on in Parkinson's disease, most people don't fluctuate. The reason being is that, and remember, we are trying to get your tank to a point where it's full of the medicine. It's full of dopamine all the time, right? Early in Parkinson's, people tend to be younger because the average age of onset is 65. And as you progress, as you go down this journey in Parkinson's, you're also getting older. But early in Parkinson's, you also have a good buffering capacity. Your body is producing a lot of natural dopamine. There's still a good sponge in there to hold on to the stuff we're giving you. So that window between enough medicine to be better and too much to get a side effect, this thing we call the therapeutic window, is really big. So we can give people Sinemet 3 times a day, and it shoots up like a rocket, but the fluctuations tend to stay within that window. So people are good, right? That's why early in Parkinson's, we can really throw most medicines at people and they just feel better for a period of time. But then after a period of time, the average is between 3 and 5 years, that window starts to narrow and people start to feel the fluctuations of their medicine. Again, listen to what I said. I didn't say the fluctuations of your Parkinson's. I said the fluctuations of your medicine. And so what will happen now that that window is smaller, folks will need to take Sinemet more often because it's only lasting for a couple of hours. And then they can bounce between symptoms of too much and symptoms of not enough or being off. So how do we take that idea, which I would put $1 on the table that a lot of people in this webinar experience day in and day out? How do we take that and then talk to our docs about it? It's a big question. It's an important question. So my advice is a couple of things. Number one, resist the urge to be a good patient. We all want you to be a good patient. We want you to be your best, of course. But I can't tell you how many times folks come to clinic and I ask them, how are you doing? And they say, I'm doing fine. I ask, what's wrong? Well, I've got some things I want to talk about, but I'm doing fine. Resist the urge to do that. What I want you to do is when you go see your doctor and he or she says, how are you doing? Say, I'm doing fine if you're doing fine, but then say, I'm doing fine, but. And then tell that doctor the things that you wish you could do that you can't because of your Parkinson's, or tell the doc the things that you chose not to do because of your Parkinson's fluctuations. Then all of a sudden, your whole conversation will shift from being about what the doc wants to talk about to be about trying to come up with a plan to fix the lapses in your day. And there are wonderful things called Symptom Diaries that you can find online. There's one on Abbott's website too, where it allows you to track during the day when you're good, when you're off and the symptoms aren't so well, and when you're having dyskinesia. Sometimes this helps just guide that conversation for the amount of off time you're having with your doc. I also recommend to folks you make a list of the things you want to talk about during the visit and give that to the doc at the beginning, not at the end, at the beginning, to help guide the conversation. Because you gotta have a little bit of courage. You gotta realize that you are there to be an advocate for yourself, and you're there to try to get you better. So asking questions, asking pointed questions about your treatment and different paths forward, and asking about your off time is beyond perfectly allowed, but it should never offend any doc, because at the end of the day, that's you taking an interest in your disorder and really being an advocate for a path forward that's better. Because at the end of the day, my job is to be a partner with you in your care and to maximize the time during the day when you're on, when the medicines are working without dyskinesia, because we can do that nowadays. Because as you get older, the pathways of the brain age, and it becomes harder to find that good point where things are good. Because we are balancing not only age, but that deficiency of dopamine growing slowly over time, but growing to a point where we really are dependent on the medicines to fix the problem. And so if you're fluctuating during the day, if you're having a lot of periods where you're having less and less on time, especially with dyskinesia, if you're having on time with dyskinesia, we have to think about a different tool or a different path forward to try to fix things. And that's where we tend to talk about DBS a lot, because we talk about DBS in the role of being a tool that goes to the source of the problem to shut off the symptoms of Parkinson's, to allow us to lean on the technology to make things better in an incredibly smooth and predictable way. And then we can also back off on the medication. Because we've known about, as we'll go through in a minute, we have had this tool of DBS for a long time. It was first approved for essential tremor in 1996. And DBS is a device, we'll talk about it, but it goes to the source of Parkinson's in the brain. And it allows us to put therapy right where Parkinson's lives to affect change. And what does it give us? It gives us more hours of on time, significantly more, that we'll talk about, better control of your motor symptoms, better fluctuations. And we usually with DBS can reduce people's medication by 60 or 80%. All of a sudden, we can lean on this device at the source of the problem to shut things off and just supplement with medicines. And then as things progress, as time goes on, we can always introduce more medicine, because then we have them because we're not using them. So let's talk about what that means. So if nobody's ever seen a video of DBS, let this be the first. So this is a wonderful lady who has Parkinson's with resting tremor, as you can see. And on the left is when her DBS is off. On the right is when it's on. So when we turn it on, when I turn on the video, you can see she has pretty profound tremor. And it's tremor not only in the right side, but also some on the left. It's definitely right predominant. Parkinson's is a condition that always affects one side of the body more than the other. And for her, her right side is more affected. Now, if we now look on the right and we turn on her DBS, this is an instant response. It made her tremor stop. That's pretty profound, right? It's a wonderful thing to offer to patients, and it is an almost religious experience every time we turn on a DBS device, only because the results are so quick, they're so instant, and they're, profound in terms of what they can do. The reason why, let me skip to the next one. There we go. Oh, here's another gentleman before I get to that. So you can see him on the left, his DBS is turned off, and he has a pretty significant right-sided tremor. And now on the right, you can see once he turns it off, how quickly that tremor just stops. It's the greatest party trick too. If you have DBS at Thanksgiving, you can always wow the family by turning it on and turning it back off, but it works. And now folks always attribute DBS to tremor. People always say, oh, well, it just works for tremor. Well, we'll talk about that more in a minute, but just remember, deep brain stimulation, or DBS, works on all of the symptoms that the medicine works on, just better, smoother during the day. So for this gentleman, if you notice, on the left, he has a very Parkinsonian type walk. It's very short step, very shuffling. He doesn't swing his arms. He needs a walker or a cane to help stabilize himself. Well, for this gentleman, when he took medication, his walking got better. It wasn't smooth, it wasn't consistent, but it improved. And because his symptom got better with medicine, when he did the DBS, his walking got better too. And so you can see the difference between his walking before DBS and now with DBS. These are important things to remember because DBS does not just work on tremor. DBS works on any symptom that the medicine will improve. Really, think about deep brain stimulation as electrical cinematic. It's going to the same pathways in the brain that Cinemet or Carbodopa, Levodopa is going to. It's exerting the same influence the pill does, except instead of giving the brain dopamine back, it's just calming down and blocking the pathway that's firing abnormally because the brain doesn't have enough dopamine. So let's hear what Olson thinks about his DBS once he got it. I'm going to let it play.
And I wished I had done it earlier. I really do. I could sculpt again. I could do my digital painting, all kinds of writing. I couldn't do any of those things before. I still have Parkinson's.
Oh, it froze. Sorry, guys. Let me play again.
But nobody knows it. That in itself is a huge thing, to be able to interact as a normal person. Just be normal. That's all I want. That's not a lot to ask. The game changer really was being able to get back to sculpting and to have that fine motor control that I never had in the past. For 10 years now, I've been waiting for it. And I used to say to myself, if I could just have one day, just give me one day. And now I've got every day. It's amazing.
Okay, guys. And, we always think about this as, especially in this kind of context, that Olson is the cherry pick patient for this kind of presentation. But I promise you, doing this a lot, we at our center implant 2 to 3 DBSs a month. This is DBS. This is what deep brain stimulation gives people back, because it is just a tool that goes to where we're trying to exert change and allows us to do so. Now, like I said, DBS has been around for a long time. In fact, in the late 1940s, really, we first discovered that we know the pathway that Parkinson's lives on. We know the pathway that it runs on in the brain. And we used to, in very complex or advanced patients, we used to put a probe into the brain to go to that pathway and burn a hole to block it. It's called a lesioning procedure, a thalamotomy or pallidotomy. And it worked. I mean, we know the pathway. If we create injury and block it, people would get better. It was a big thing. It was a big thing because all of a sudden we're adding a structural problem on top of a chemical and electrical one. And then the body tended to work around it. And then what would we do? We'd go back in and burn more holes. Well, we discovered very quickly in the 1970s and 80s that if we put a probe in and turned it on, that when that electrical current would get to a point that was much, much lower than creating injury, the symptoms would get better. And then it was the late 80s and early 90s where we realized, and we created this technology, DBS, that if the brain is a collection of electrical pathways, it's all signaling, right? And if we know that the symptoms of Parkinson's are a pathway firing incorrectly or aberrantly, and we know that when you take your medicine and the symptoms get better, that pathway calms down. Well, that's what we created with DBS, was a way to put a lead in that pathway where we could deliver controlled energy to force that pathway to calm down. And guess what? Because it's energy through a device that we can adjust and program, it is a tool that becomes part of our clinical path. It becomes part of our toolbox. Every visit, we're talking medicine, therapy, how life is going. We're also adjusting that DBS to better calm that pathway. I don't want you to overthink it. So with deep brain stimulation, how I couch it to patients is I tell folks that it works very much similar in a very physiologic way to those giant noise canceling headphones that people tend to think about when you're on the airplane. You know, the big Bose noise canceling headphones. Well, noise canceling headphones work because it has a microphone on the outside that listens to the noise in the room and then will broadcast to your ear the opposite sound wave, thus canceling it, making for silence. That's all we're doing with DBS, guys. We're putting a noise canceling headphone into that pathway and tuning it to block that signal and make the symptoms stop. And so people always want to know, well, how does it work? Because it is continuously operating, because it is adjustable and adaptable, it's a device that is part of you. We implant it. It's all in the inside. And it's built off of a very similar platform as a pacemaker. So it has a little box, a little generator that lives under the collarbone. And instead of the wires going into the heart like a pacemaker, they go up behind the ear and down into the brain to get to that pathway. And those leads are all on the inside. You can't see it from the outside. And it actually communicates with the device that we use to program, with your device or mine via Bluetooth. So it's nice and secure. And what's nice about it is, again, if we're dealing with this window between not enough and too much and side effects and your fluctuations between them, well, DBS is constant. It's 24 hours of stimulation at the source of the problem where the medicine's trying to get. Well, if that's the case, then we can back off on the medicine. We can lower the fluctuations, which the fluctuations were the medicine. And that's why people get better. People get better because we can make the dyskinesia go away. We can make the off time much better. We just smooth it out. Now, people always ask, when is the right time to talk about this? This is a big thing. I tell people it's a big step to get, but then it is a lifetime of a therapy that really works. So read the screen, guys. According to the FDA, the strictest law in the land, to be a candidate for DBS, for this life-changing therapy, you need to have only had symptoms for about 4 to 5 years. 4 to 5 years. That's a lot of people. That's right when most people are starting to fluctuate. Of course, you have to be a good candidate for surgery. And the big no-no is we don't want people to get DBS if you have established dementia. Poking the brain in any way is never a good idea when there are cognitive issues, but mild age-related cognitive stuff is fine. So that's why for anyone who wants to go for DBS, we usually do some cognitive testing ahead of time just to make sure all the nuts and bolts are in the right spot. And the final thing is, to be a candidate for DBS, your symptoms have to get better with medicine. This is electrical cinemet. Whatever the Levodopa does at its best, that's the expectation of what DBS can do all the time. And so the real ideal window is not last resort. It's not severe end-stage symptoms. In the US, the average time from diagnosis for DBS is 13 to 14 years. That's when people, especially in older regimens, when we're trying to recover function instead of restore it. The best time for DBS is that window when the medicines aren't working as well as they did, and when you feel like you're starting to kind of fight against them. If it's not just easy, if taking 3 to 4 pills a day and you're great, that's not the time for DBS. The time to start talking about is when you start to fluctuate. You feel the ups and downs, and we're adding and trying to change to try to fix it. That's the best time to go to DBS, reset the script, back off on the fluctuating medicines, and just get you better when you need to be your best, when you're in your 60s, 70s, early 80s, when you want to go out there and go on those cruises and go live life. That's when we need to give you this life-changing therapy. And so we talk about it in our clinic right when people are starting to fluctuate. We bring up the idea to at least have it be part of our conversation from that point on. Because it's profound, guys. It works like, again, think about it as electrical dopamine. It works to suppress those pathways that cause symptoms. It can be changed, it can be stopped, it can be adjusted. You even get the programmer on your own phone where you can connect to it if you're having a rough day and turn it up, or if you're feeling especially well, you can always turn it down. Because of that, it gives us a therapy that's adaptable. It's adaptable for you day to day so we can adjust it to meet your need. And so again, I don't want to overstate this. If you have symptoms that get better with levodopa, that's the expectation that it should improve with DBS. So if you take medicine and your rigidity, your tightness, your slowness of movement gets better, your tremor gets better, even if your walking gets better, the DBS should make those better, except all the time. And even if you're dyskinetic, if you have excessive movement, that's a symptom of too much medicine. That's another reason to go to DBS, because then we can lower the medicine and get the dyskinesia to stop. Now, there are always symptoms that don't respond. Now, if you take medicine and your symptoms don't get better, then that symptom is probably not going to change with DBS. So if you have walking issues, freezing, stuttering of your gait, and you take medicine and it doesn't change, probably not something that DBS is going to address. If you have swallowing issues, small handwriting, the postural instability, those things might not respond to DBS. So always talk to your doc. We always have a good conversation about this before we take that step. People always want to know what's involved. So DBS is technically 2 procedures to get it implanted. Again, a big step for a lifelong therapy that we can use to help. So the first procedure is in an operating room. For a lot of patients, it's actually an awake surgery because we want you to participate in the surgery to confirm that it's in the right spot and that your symptoms get better. People tend to think that's a scary thing, but we do it every day. And patients actually kind of like it because for the first time in however long, you get to feel your symptoms go away. And so what happens in the procedure is that we use very complex mapping software to make sure it's, of course, going in the right spot. We put the lead into that deep part of the brain where Parkinson's lives. Then we get you to do a bunch of stuff. Then we turn the device on, the lead on, and we get to watch the tremor stop, the dexterity improve, symptoms just melt away. That confirms for us that it's in the right spot. So then they close it up, they put it all in, and then you come back, usually in our center, a week or 2 later, to get the generator put in and get it all hooked up. And that's in a sleep surgery. Then what happens is we give you a month to heal. You go home, you take it easy. After about usually on average 3 to 5 weeks, you then come see your movement doc or your neurologist. We turn on the device. We map out where those leads are in the brain by testing how you do. We find the best setting. We send you home. And then what we do over the next few months is we adjust. Because what we need to do is we need to slowly bring down the medicine and ramp up the DBS. And it's all about finding that balance between the medicines you need and the DBS and its effect. It takes time. I tell folks on average about 4 months to really find that perfect spot. Then, from then on out, it's your normal clinical visit with us, except instead of just adjusting the medicine, instead of just sending you back to PT, we're also going to adjust the DBS too. The nice part is it's covered. It's considered standard of care. So if you're a candidate, it should be something that's extremely well covered by your insurance. But again, you can always ask for a cost estimate up front. Now, there is no cure for Parkinson's or essential tremor. These are just treating the symptoms. As with most things in medicine, we can treat it, we can't cure it. It is surgery, so there are risks of the surgery that you'll go over with the surgeon, of course. And in terms of the stimulation itself, we can tickle the wrong pathway or put it in the wrong spot, the energy, and give you side effects. But the nice part is with the programming, we can usually make those better by just programming the device differently. But again, before you go through DBS, you will, of course, have a long conversation with the surgeon and your movement disorder team about the risks. So that takes us to Abbott directly. In fact, I'm going to go to this one. The system has evolved over the past 10 years. 10 years ago, we just had Medtronic, which was a good system, life-changing, but it tended to be very dated because their hardware dated to early 2000s. All of a sudden in 2015, we had St. Jude, which is now Abbott, come out with this directional DBS system. We have Boston Scientific now in the market. And we've created a sense of competition that has resulted in advancement of technology that only benefits you and me as the doc. Because we can do DBS better now than we ever could have, because our technology is now advancing at a rapid pace, and it's super cool. And so this picture is showing us what's really neat is that my programmer is an iPad. You get a little iPod Touch you can adjust your device on, but you can also have it loaded onto your own cell phone to go in and turn the settings up or down. And it allows that Bluetooth connection, allows us to do really neat things, including remote programming, which we'll talk about in a bit. So one of the neat things about these newer technologies is that now the leads, that part that goes into the brain that delivers energy to turn things off, they're now what we call directional leads. They're leads that allow us to put the energy where we want, not where we don't. This has been the biggest advancement in the world of DBS in the last 10 years. And so I want folks out there to know is that if you are going for DBS or even thinking about it, please, please, please make sure you are getting a directional lead. There is no reason in the world to get a non-directional lead these days, because that is essentially doing DBS as we could have in 2000, realizing then that it was an inexact science, that we really needed these directional leads to do it well. And in fact, we have data that supports that. This study called a progress study, which was the largest directional DBS study that's ever been completed, showed that when you compared a non-directional, the old leads that go in the brain versus these directional leads, that 90% of patients were better, had a superior window in the directional lead versus not. It's the way we always should have done DBS, but technology has finally caught up where we can do it. So please make sure you're using a directional lead. And the Abbott system is the one that we use at our center. It's the preferred one at our center, mainly because it is a system that really, they created the directional lead. They built it and marketed it before other companies did. They know it well, and their system is built to optimize it. And on top of that, we have with the Abbott system, as we'll talk about, the ability to use your device to adjust your program or to adjust your settings, and also remote programming where we can hold a telehealth visit through your device, adjust the settings without you coming into clinic, which is super cool. I'm going to skip past that real quick because I know we're running out of time. Now, this is something I did want to talk about. I'm sure we'll get some questions about it. We have the ability with the Abbott system. This is what Alex mentioned early on. It is FDA approved as a medical device, but also as a telehealth platform. We have the ability securely to connect to folks through your programmer and then adjust your device through your programmer. This has been an incredible benefit to the patients in our clinic because telehealth has done nothing except increase access to specialty care neurology. And so that's what this picture is showing us, is that on your device, be it your phone or your programmer they give you, we have the ability where I'll pop up in like a FaceTime window, see how you're doing, do our telehealth visit, see how you're moving. And then on my screen, I have all the settings that would be there in person, except remotely, where I can adjust your device to make your symptoms better. It's secure, it's really quick, it's super slick, and it works. Look, I had a patient the other day who was on vacation in Spain, had trouble with her tremor, probably because of the stress of travel and everything else. We did a telehealth visit from Spain. There was no lag. It worked right away. She's now enjoying the rest of her trip with no tremor. This is the future. This is the now. I don't even have the same cell phone from 4 years ago. We are all advancing technologically. Now we get to employ that with some life-changing technology like DBS just to make access accessible. And so what's nice about it too, is super secure. You as the patient actually have to confirm the connection multiple times. And it is protected, it's shielded, it's A-okay. Oh, and then the other thing they put down here is, remember, if you have Medtronic leads, if the leads in the brain are Medtronic, Abbott, even Boston Scientific have adapters where you can pick a different generator where all the software lives to connect to the old contacts. And so if you have Medtronic leads and you feel like, oh, I missed the boat, all this new cool technology I can't access, you actually can. Have a conversation with your doctor, make it an informed one about the next time you need to change out your battery, to consider updating to a different piece of technology that might give you some benefits that the old one didn't. Okay, and that's virtual clinic. Cool part about it, on your screen, you get a little network indicator that says if you have the bandwidth to do it, you can turn your camera around just like FaceTime. You can always end the session. You can mute yourself. It's just like FaceTime, except it's through your device. And it's super secure. The Abbott technology is a primary cell battery. It's not rechargeable. And so that gives you a less of a reliance on needing to recharge it. And if you look at the DBS system that Abbott presents, the one that we use, and this is true of all DBS now that they're all directional, is that these directional systems give people better on time, much longer periods of on time. The average is 4 to 6 hours of on time improvement. 4 to 6 hours, it's awesome, without troublesome dyskinesia. You have much less risk of side effects with these directional leads because they're just better. And because of that, we can back off on the medicine again by 60 or 80%, leaning on the technology to control symptoms through the day and night and just supplementing with medicine at that point. Okay, so how do you proceed? So what's the next step? So the next step is, of course, to educate yourself, just like this. And then if you're fluctuating during the day, if you feel your medicine's working and wearing off at times, talk to your doctor about DBS. You can go to Abbott's website. There's all kinds of great resources out there. And if you don't have a movement doc, which yes, you need a movement specialist to be part of your team because of the tools we have. You got to do this every day of the week to really know how to use these tools. There's finddbsclinic.com to help find a specialist near you. So that's what I got, guys. I hope that was educational. I hope that was informative. I hope I didn't drone on too much. I hit right at 55 minutes. Thought that was a good mark too. I am Dr. Drew Falconer. I'm here for the next little bit. However long Alex wants to have me. I hope this was a helpful thing, and I am here to answer any questions you have about Parkinson's DBS on down. How's that fine for a fine deal, Alex?
Excellent. I want to thank you so much for attending today, everybody, and for Dr. Drew Falconer. What an animated speaker you are. And you connect so well with people. A wonderful physician that actually speaks so we can understand what he's saying. So kudos to you. That was absolutely a wonderful presentation. And we look forward to having you back. I'm pretty sure that Shri will be able to arrange something where you can come on and go full screen and just do a Q&A. I know that,
Q&A.
Yeah, we'd love to be able to have you do that. So we're bringing you up full screen right now, and then whoever's speaking will be full screen for the Q&A portion. And then Shri, Dr. Shri Palavaram is coming back on right now to ask your questions. I'll hop off and then I'll come back on and say goodbye. So our audience, please stay with us because I'm sure you don't want to miss on this, and it's a great opportunity. Type into the chat and Dr. Palavaram will present those questions to Dr. Falconer. So stay with us.
Thank you, Alex. Dr. Falconer, as always, fantastic. Thank you very much. I'm sure it was helpful to patients and their caregivers. There's some very interesting questions, one of which you addressed, so I'm just going to reiterate. How much time does it take to recharge the IPG? Like Dr. Falconer said, the Abbott IPGs are recharge free, and so you don't have to recharge them. Once you implant them, they're set for many years, and then you just have to get the battery replaced. Dr. Falconer, would you mind elaborating on how simple or complex the battery change procedure is after several years of using it without having to recharge?
Sure. And it's a great conversation to have with your team before you pick a DBS device, because at our center, we offer all three systems, and we sit down with every patient and just have a conversation about what device would be best for you. I hate to minimize it to buying a car, but if you think about that analogy, when we all go to buy a car, we have a list of the things we want and we need that fit our lifestyle that are very different from person to person. And it's actually different as time goes on. I mean, before I had kids, I had a different list of what I wanted in a car versus now that I have two kids who are in sports and I need all of the storage trunk space that I can, right? So part of it is finding the right device that fits you. And we have recharge and non-recharge systems. There are some systems where you can have a battery that is rechargeable, that is guaranteed for about 15 years. But the trade-off is the battery doesn't hold a lot of excessive charge. So if you miss a recharge interval, it can shut off. And you also have to then remember to hook yourself up to it to recharge it. It works for some people. For most people, though, people like not having a rechargeable system because you just go and live life. And instead of a 15-year window, we just have to worry about changing out that battery when the battery dies, which in our center is averaging between 5 and 7 years. So you go out there, you live life, and it's a quick outpatient procedure. They just knock you out, take the old one out, plug in a new one, put it back in, stitch it up. I think our surgeon can do it in about 26 minutes, he's told me, and that's including the knockout time. It's a very quick thing. And so for a lot of our folks, they like just not having to worry about recharging it. They just go out there and live their lives. Is that a fair answer?
Yep, absolutely. Thank you for that. I'm just going to combine a couple of post-surgery as well as surgery eligibility questions into one. Is there an age window for DBS suitability, eligibility, ineligibility? Is 80 too old? Is 38 too young? How do you recommend people think about that?
That's a good question. I always resist giving a direct answer to age-related questions, only because technically there is no age limit, but every center has a different kind of threshold that they look at in terms of that age window. I can tell you our center, which is as you get into your 80s, the potential for benefit does wane. What I mean by that is that when you're 85, your brain is different than when you're 75. I mean, obviously, the 80s are different than the 70s. Everyone knows that. That's one of the things that is why we got to get you living your best in your 60s and 70s, because the 80s will do what they're going to do. But the reason why the brain changes in the 80s is that the structures of the brain are shrinking. Just like the rest of everything, that's what age does. And so when you're in your 80s, putting stimulation into a smaller pathway is harder than when you're younger. So for a lot of folks, we have this, and our center is too, we have this kind of mental cutoff at the early 80s where we just need to have a conversation about the response maybe being not as profound as if you were younger. Now, that being said, at our center, I think the oldest person we implanted was an 83-year-old who was otherwise healthy. She was a runner and would run miles and miles a day and wanted to get back to that. And she did fantastic. So the point to that is, don't make it an age thing. Make it a question about how you're doing every day, how you're responding to your medicines, and how your symptoms are fluctuating. And then take that to your doctor to then talk about whether you're a candidate.
Great, thank you. I'm going to combine two questions into one again. There's a question that came up about cognitive issues. So what criteria do you use before, and how do you advise people in terms of DBS outcomes on cognition, if any? And then I'm trying to combine that with another question that came regarding focused ultrasound. So comparing the pros and cons of reversibility, irreversibility, unilateral, bilateral, indication approval for PD, ET, as much as you can in one.
So in terms of cognition, part of our workup leading to DBS involves cognitive testing. We all get cognitive issues as we age. If you guys don't know it, it's out there. We tend to quote that at age 70, 70% of people have mild cognitive issues. At age 80, it's 80% of people. But these are all mild age-related changes. It's a normal part of it. It's a little forgetfulness, a little bit here or there. It's not something that we would consider significant or pathologic, right? In fact, if we do cognitive testing on people over 70, most people have little things. All okay. It's all part of the beauty of life and you being who you are. That's okay for DBS. It's when we start to get more profound cognitive issues that poking the brain with anything, let alone DBS, runs the risk of making it worse. So what we do is we do this cognitive testing beforehand, and the neuropsychologist that does it for us actually does it with DBS in mind, and will then advise us as part of that testing, the patient is good for DBS or not. So we tend to cover our bases because we want to be safe. So if you have cognitive issues, that's not a reason not to talk to the doc, but again, a great reason to bring that up when you're having that conversation about DBS. Now, the second question was about focused ultrasound, which is a whole different ballgame. So focused ultrasound is a reminder that sometimes what is old becomes new again. And in fact, I mean, my wife is now telling me that scrunchies are coming back and other things from the 1980s, which is what is old is new again. I wish they would have the leg warmers come back because it's going to get cold here soon. But the point to that is, with focused ultrasound, all focused ultrasound is doing is it is a non-surgical way to create a lesion in the brain. Remember back when we were talking about the history of DBS, we used to put probes in the brain to heat up to create injury to block this pathway. It was very limiting in some ways because once you create injury, it's there. We're then dealing with a structural problem on top of a chemical and electrical one. And the brain likes to be pathologic. It tends to work around it and bring symptoms back. The other thing is, anytime we create injury, a lesion, we can only do it on one side of the brain safely because it's permanent. And so if you do it on both sides and hit a wrong thing, you're toast, right? Well, focused ultrasound creates lesions. Everybody thinks about ultrasound as this safe, oh, we do it on babies. But in reality, focused ultrasound for Parkinson's or Tremor uses about 1,000 ultrasound beams to focus on a point in the brain. And when all those sound waves come together, they create heat and they create injury. It's just a more modern, less invasive way to create a lesion. And so in my world, at least my opinion is, I'm always very cautious to create a lesion because it's permanent, because we can't adapt it, we can't adjust it. It is what it is. It's still limited to one side of the brain for Parkinson's. So if you have Parkinson's, both sides are affected. That's how it works. Focused ultrasound makes you pick a side, and that's all you can get. So we haven't done a focused ultrasound procedure in our clinic in the 5 years it's been available, and we've had access to it only because we prefer DBS, because DBS, you can put it in both sides. It's adaptable, it's adjustable. We're playing for the now as well as 10 years from now when we can still use this device to adjust. And in fact, in our clinic, I have a number of patients who had focused ultrasound elsewhere on one side, have a DBS on the other side, because once you have injury, you can't get DBS. And these are patients who, if you look at them, the DBS side is much better than what the focused ultrasound side is. And so I tend to cautious folks on jumping on the marketing bandwagon of what ultrasound is. Just have a really good conversation with your doctor about why you're going to do ultrasound, and also how does that project out over 5 or 10 years. That's my advice.
Great. Thank you. Keep an eye on the clock. I'm going to wrap it with one last question, combining two. But for that, I'm going to share screen. And as I mentioned the question out, there was a question on outcomes. So I'm going to leave this for a few seconds, Dr. Falconer. So go at it, if you will. And then the next slide will leave with contact information, because somebody was asking, how do we find physicians? So I'll let you take it.
Fantastic. And I'll just put out there that Alex is absolutely right. I love Q&As. In fact, there have been a ton of questions I've seen flowing through. So sorry to everyone we couldn't get to. We can find a time. I'm always happy to come back and just answer people's questions. It tends to actually be a really fun hour of time because we talk about what you want to talk about and it builds from there. But people always ask about outcomes. There is nothing in the world of movement disorders and Parkinson's that even compares to outcomes in DBS. DBS just makes things better. And if you look across the quality of life markers that we have available, nothing touches DBS. So there's a big study that actually just came out of Europe of 15 years of DBS. How do people do after 15 years? By the way, after 15 years, they were still getting effect of the DBS. It was still working. So if you ever hear people say, oh, it only works for a couple of years, this is big data that shows that that's not the case. And that DBS after 15 years was still more effective than the medication by itself. And that we had dyskinesia, the excessive movement, still reduced by 75%. The time in the off state compared to the medications alone was reduced by 60%. And even after 15 years, the amount of medicine people needed were 50% less than people who didn't have DBS. And then if you pick any outcome measure of quality of life or how people are doing, anywhere from 10 to 50% better with DBS compared to not. So the point is, and it goes back to how we're treating this thing called Parkinson's. Or do we have you on a roller coaster of medicines going up and down? Or are we just going to the place where it's coming from and shutting it off all day and all night? And surprise, even after 15 years, we are measurably better with DBS compared to not. How's that for a fair deal?
Yeah, thank you. Yep. I'm going to wrap with this slide. Somebody was asking about how do we find physicians. If you go to abbottdbs.com, that's the compliant way we can suggest. We cannot directly put you in touch with physicians for good reason. But you also have these email addresses on the screen. You can get in touch with Chad, Quincy, or myself. I would say just take a screenshot of the screen that you're seeing and send us an email later. With that, I'm going to hand it off to Alex. And thank you so much, Dr. Falconer.
Absolutely. We'd like to thank Dr. Shri Palavaram. We'd like to thank Chad Davey, who's your local Abbott rep. And we'd also like to give a huge thank you to Dr. Drew Falconer.